So a very good evening, everyone. The burden of CKD in India is ever increasing, and the pooled prevalence of CKD is as high as 13 to 17% according to some data sources. So today we are gathered here to discuss this ever increasing disease burden in India. So I am really honored, and please join me in welcoming Dr. Mahendra Singh Suri. He is a leading expert in this subject matter and its complexities. So Dr. Suri is a senior physician and diabetologist at Sudha Hospital and Research Center in which is in Kota, and in Suri Diabetic and Heart Care Center in Kota. He has previously been the head of the Department of Medicine at Global Modi Hospital, Fortis Modi Hospital, and Apollo Modi Hospital in Kota as well. And previously, he has also been a medical officer at Government of Rajasthan. So today's discussion, protein and CKD, which why is it yes and no, promises to be an enlightening exploration of the protein CKD paradox. And Dr. Suri's expertise will undoubtedly provide valuable perspective on this critical aspect of CKD care. So over to you, sir.
Thank you. Thank you for the nice, kind words. Are these slides visible?
Yes, sir, they are. So if you can put the slides on presentation mode.
Slide mode, yeah, right.
Yes, they are good to go.
So, good evening, everybody. It's pleasure to talk to you all on CKD and protein levels, what amount of protein one can eat in CKD patients. Today, we'll be discussing about the same. Now, as Mr. Ankur said, CKD is extremely common and has emerged as a leading non-communicable cause of death worldwide. It is projected to affect an increasing number of individuals over time and to further rise in importance of disease among various global causes of death. The higher number of affected individuals and significant adverse effect on health prompts us to take preventive measures aggressively to prevent the chronic kidney disease. So the global scenario is also not good. About 10% of the general population affects patients develop CKD, and 48% of those with severely reduced kidney function are not aware of CKD. That's very surprising because it's a silent disease and patient comes to the doctor when the disease has increasingly progressed. So diabetes and hypertension are the leading cause of CKD today in India and worldwide. And the consensus of 2017 showed that there were 843 million kidney patients in the world. And today, 1 in 3 is approximately 1 in 3 of diabetic patients is being affected by kidney disease. And the ESRD data of United States suggests that 44% of the diabetic population have CKD and 29% of hypertensive patients have CKD. And coming to Indian scenario, A.K. Singh et al. In 2013 cross-sectionally screened 6,000 patients from 13 academic centers, and they found that CKD was to the tune of 17%, and 6% had CKD stage 5. Now, the prevalence of CKD stages from 1 to 5 maybe 7%, 4%, 0.8%, and 8% respectively. So the disease is increasing in country and all over the world. And the ICKD study has shown 37% of the diabetic population have CKD. And in our own practice, we have also seen that 30% to 35% of the diabetic population patients develop CKD. So CKD is a progressive disease and is like spiral downwards. And CKD eventually progresses to ASRD if untreated. uh, in due course of time. And hypertension and diabetes increase the process of uh, deterioration of renal function uh, in shorter period of time as compared to natural history of disease. So now kidneys physiologically adapt to decreasing function. Now this slide shows that healthy kidneys have all normal functioning neurons, and the second part of the slide shows that 20%, 10% of the nephrons are damaged, so 90% have to work more. So when 25% of nephron gets involved, 75% functioning nephrons have to increase their work, and they have harder to work to compensate the uh, non-functioning part of the kidney. Similarly, when 70% of the nephrons get damaged, only 30% of the nephrons are subjected to more hard work. So that leads to hypertrophy of the remaining part of the kidney and deterioration of the renal function in the similar way. Uh, we can briefly talk about management of CKD, and in this algorithm, we have shown that basic lifestyle measures are always important in non-communicable diseases like healthy diet, uh, regular physical activity, smoking cessation, and weight management. These 4 points are very important in preventing the deterioration of kidney function. First line drugs, if patient is diabetic, then SGLT2 inhibitors and metformin. Uh, uh, and regular assessment is done. And if albuminuria is high, BP and lipid profile is high, we can switch over to blood sugar levels are not maintained, then we can switch over to GLP-1 analogs and try to maintain glycemic target below 7. For blood pressure, we have ACE inhibitors and ARBs, and we may add now the newer drug available are SGLT2 inhibitors and finerenone, and both are effective in reducing the brunt of kidney damage, and they maintain the GFR uh, to later uh, years as compared to normal course of disease. So finerenone is also having anti-inflammatory and anti-fibrotic effects, and is a non-steroidal MRA and is very useful. And recent trials in last 1 year have shown that the drug has very promising effect in treating CKD patients. We need to have moderately intense treatment with statins if lipid profile is disturbed. And if blood pressure doesn't get controlled with SGLT2, RAS, ARBs, or finerenone, then we may add dihydropyridine calcium channel blockers and try to maintain blood pressure around 140/100, 140/80. So this will be the nutshell how we manage kidney patient with hypertension and diabetes. Today's topic is protein restriction in CKD, whether it is advisable or not, and we are going to talk about this today. Uh, High protein intake may lead to increased intraglomerular pressure and hyperglomerular filtration to start with. This can cause damage to glomerular structure, leading to aggressive chronic kidney disease, and hence uh, low protein diet is advocated in patients of CKD. So the recommendation suggests 0.8 grams of protein per day may be given with patients of CKD with diabetes and patients who are not on dialysis. And patients treated with hemodialysis or peritoneal dialysis need increased intake of protein from 1 to 1.2 grams per kg per day because of the protein loss in dialysis. Now, animal proteins and plant proteins. Animal proteins are from meat, poultry, fish, seafood, and eggs, dairy milk, yogurt, cheese, and plant proteins are from legumes, dried beans, nuts, seeds, cereals, and starchy vegetables. And now there is again a thought process that which protein should be preferred in patients with CKD. And the data suggests that it does not matter whether this animal protein or plant-based proteins are given to the patients of CKD. But in general, we would prefer vegetable proteins in CKD with diabetic population. So now comes the point that whether low protein foods are helpful or in CKD or not. Now there is a situation where we can give low protein foods and very low protein foods. So whether they are helpful in treating patients of CKD or not, this is the point of discussion today. And I would say that very low protein given in CKD patients is deleterious effect on the health of the patient. So low protein diets are advised to reduce workloads on kidneys and minimize production of uremic toxins from protein metabolism. However, very low protein can be problematic because of the reasons that patient can develop malnutrition in cases of uh, very low protein intake, and that can lead to muscle wasting, weakness in patients of CKD. Then very low protein diet can cause frailty and fragility in patients of CKD, and they can cause excessive fatigue, and they can disturb the energy levels in the body. Then very low proteins can also cause impaired healing and low immunity in patients of CKD. So they may have delayed in recovery from infection and certain illnesses. Then there is an individual variability also. Then appropriate protein level will depend on stage of CKD, presence of dialysis or no dialysis, and patients with diabetes or no diabetes. So patients on dialysis will need higher amount of protein as we have discussed just now. So protein restriction is advised in kidney patients. Now, very low protein and low protein. So if very low protein is given to the patients, then the patient can have these problems which I have narrated just now. So they need to have supplementation along with very low protein diet so that the basic health remains good in the patients of CKD. So in 2020, the Kidney Disease Quality Outcome Initiative gave guidelines for nutrition in CKD patients, and they stated that protein restrictions in CKD not on dialysis and without diabetes may be zero point 0.6 to 0.8 grams per kg. And patients with CKD stage 3 to 5 who are metabolically stable we can be kept under close supervision and protein restriction with or without keto acid analogs to reduce the risk of ESRD and improve quality of life. So, as I just told, that very low protein diet will need supplementation, and keto acid analogs are available now, which have been recommended by the guidelines, and we'll be talking about keto acid analogs, when to give and how to give. Now, till date, there were many guidelines which suggested different protein intakes. The latest is KDOQI guideline, which suggests that if GFR is less than 25 ml per minute, then the protein intake should be 0.6 grams. And the UK Kidney Association recommends 0.8 to 1 gram per kg per day if the GFR is less than 30 mL. But we are now following the guidelines suggested by Kidney Disease Outcome Quality Initiatives guideline, which have been recently given in 2020. This is the same slide which I just talked about. And the low protein intake may be 0.5 to 0.6 grams per kg per day as advised by Kidney Disease Outcome Quality Initiative, and very low protein diet would be 0.28 to 0.43 grams per kg per body weight. This is the latest guideline available. Earlier in 2012, it was 0.8 grams per day per kg body weight. Now, KDOQI guidelines 2020 have suggested that patients not on dialysis, and patients not having diabetes, they would advise 0.5 to 0.6 gram protein per kg body weight with or without supplementation by keto acid analogs. And 0.28 to 0.43 protein grams per kg body weight with keto acid analog supplementation. Without supplementation, it will have deleterious effects on general health of the patient. Then in patients who are diabetic but not on dialysis, 0.6 to 0.8 grams per kg body weight of the protein can be given. And patients on dialysis or patients of post-renal transplant, the guidelines suggest that 1 to 1.2 gram per kg body weight protein can be given to patients on dialysis with or without diabetes. In stage 3, 1 to 3, or patients with post-transplant, the energy intake advisable would be 25 to 35 kilocalorie per kg body weight. And the post-transplant patients, no difference has been seen in patients whether they are given animal or plant-based proteins. And CKD in stages 1 to 4 and in post-transplant patients, uh, Mediterranean diet may improve lipid profile. And with addition of fruits and vegetables as advised in these patients. Now, effects of dietary protein on kidney. In contrast to dietary intake of fat and carbohydrates, high protein intake modulates renal hemodynamic dynamics by increasing the renal blood flow and elevating the intraglomerular pressure. That leads to hyperglomerular filtration initially and and more efficient excretion of protein-based derived nitrogenous waste products from the kidneys. Now, this is the stage 1 of hyperglomerular filtration. And once the high protein diet is associated with hyperfiltration, together with resultant increase in urinary albumin excretion, they may have deleterious effects on kidney and other organs in the long term. The experimental studies have revealed that glomerular injury by increased intraglomerular pressure and intraglomerular flow can lead to progressive glomerular sclerosis and damage. So benefits of low protein intake on uremic symptoms would be that if low proteins are given, there may be transamination leading to alpha keto acids, which may in turn lead to breakdown to glucose and ketone bodies, which can give us energy. And the deamination may also lead to less circulating ammonia less circulating urea, and less uremic symptoms in the patients. Now, low protein diet reduces nitrogen and waste products and decreases the kidney workload by lowering the intraglomerular pressure, which protects the kidneys, especially in patients with decreased nephron capital and renal function. So low protein diet to the tune of 0.6 to 0.8 grams per day per kg body weight will lead to decrease in hyperfiltration of glomerular later stage, decrease in proteinuria, decrease in uremic symptoms, and this will further lead to decrease in metabolic acidosis, decrease in phosphorus, and decrease in oxidative stress, which may result in decrease in blood pressure and decrease in insulin resistance. Ultimately, better uremic control and uh, maintenance of kidney function. Now, a meta-analysis of RCTs, including MDRD study, have confirmed the risk reduction of development of ESRD by protein restriction among patients with diabetes and no diabetes but having CKD. It is postulated that low protein diet prevents uremic symptoms and avoids dialysis therapy despite the small effect of kidney function decline. The low protein diet may attenuate insulin resistance and oxidative stress, as I've just told, and that leads to better uremic control and delays the dialysis initiation. Now, but what would be the benefits? What would be the deleterious effects of low protein diet? So, low protein diet will lead to inadequate calorie intake, uh, will lead to protein loss and hypercatabolism, which may lead to inflammation, worsening of acidosis, and altered glucose hemostasis, which will lead to protein energy wasting and protein energy loss, and patient may become cachexic and may be may be at risk of developing infections and other diseases. So in recent 18-month RCT compared keto acid analogs in patients of CKD who were given low protein diet or very low protein diet. And the participants in the groups uh, were given energy intake to tune of 30 kilocalories per kg body weight and preserved nutritional status. Although the very low protein group showed lower risk of ESRD compared to low protein diet, the studies with longer follow-up will be required to evaluate the safety of low protein diet and very low protein diet. So protein energy wasting is the term proposed by International Society of Renal Nutrition and Metabolism. It refers to multiple nutritional and catabolic alterations that occurred in chronic kidney disease and are associated with morbidity and mortality of CKD patients. Although insufficient food intake due to poor appetite and dietary restrictions contributes to protein energy wasting, the other factors include uremia-induced alterations in such as increase in energy expenditure, persistent inflammation, acidosis, and multiple endocrine disorders that render the state of hypermetabolism, leading to excessive catabolism and muscle loss and fat loss. In addition, comorbid conditions associated with CKD, poor physical activity, frailty, and patients on dialysis contribute to protein energy wasting. And protein energy wasting, if develops, patient is susceptible to infections and increased complications. The National The recent this slide shows that the survival benefits with nutritional uh, management, and the green line in this slide shows that patients who were given less than 25 kilocalories per kg body weight energy, and the blue line suggests that patients who were given more than 25 kilocalories of energy per day. And the slide definitely shows that patients who were given less energy intake had a better survival in the due course of years. Similarly, this slide shows that if there was nutritional status was maintained in patients, then the protein energy malnutrition was avoided, then the mortality was less as compared to patients who were protein energy wasting. So now with this background, we have situation where uh, we have to avoid protein energy wasting, and we have to avoid deterioration of renal function. So we have to maintain the balance between low protein diet, very low protein diet, and uh, diet sufficient to prevent protein energy wasting. So we will need to have supplementation of nutrients when we prescribe patients low protein or very low protein diets. So balance is important. So role of keto acid supplementation in CKD is gaining importance these days, and essential amino acids need to be obtained from food because it could not be generated in the body. So keto acid analogs formed by transformation of essential amino acids, except lysine and threonine, can be utilized through their conversion to respective essential amino acids without providing the nitrogen products. So proteins, amino acids, and keto acid supplementation may be effective in improving protein energy wasting irrespective of etiology. So patients, as now we are, uh, now that's very clear that with very low protein diet, nutritional supplementation is required in patients of CKD to maintain the general health. And keto acid analogs have been proposed primarily in patients who are on very low protein diet, that is 0.28 to 0.4 grams per kg body weight. So essential amino acids and keto acid analogs supplementation helps in maintaining the protein energy status without increasing the nitrogen waste products. That is important. Now, keto acid analogs reduce supplementation will reduce phosphorus and acid load given no phosphorus in purified essential amino acids and keto acid analogs. Then decreasing the protein degradation and enhancing the protein synthesis is also possible when keto acid analogs are supplemented. Now, more than 25% less protein intake on long-term basis leaves the patient susceptible to infections and compromise the metabolic balance. Hence, supplementations of keto acid analogs becomes important. As discussed earlier, several RCT and meta-analysis studies have showed that supplementation of VLPD, very low protein diet patients with keto acid analogs and essential amino acids had benefits for better metabolic control and better management of hyperphosphatemia and anemia in patients of CKD. Then uh, we also have data and evidence to suggest that keto analogs supplementation leads to decrease in dialysis, decreases the dialysis also, and decreases the mortality risks. The longitudinal data for all CKD patients in Taiwan National Medical Health Insurance Study was done. 1,400 patients with anemia and advanced CKD were taken into consideration, which were prescribed low protein diet, and those who were supplemented by keto acid analogs. The risk of end-stage renal disease and all-cause mortality risk was analyzed in these patients. And the data suggested that keto acid supplementation was consistently associated with much lower risk of long-term dialysis and composite outcomes across the board with variety of patients with respect to baseline comorbidity as diabetes and hypertension. Keto acid analog supplementation with low protein diet decreased the risk of initiating long-term dialysis by 46% in these patients and with advanced CKD by 51%. So this is a significant number, and these benefits remain significant after subgroup analysis with respect to baseline comorbidity. So this was an important information which came out of this study to then keto acid supplementations in patients with non-dialysis diabetic kidney disease uh, was also studied, and low protein diet and very low protein diet supplementation with keto analogs should be considered effective and safe for the patients with non-dialysis dependent diabetic kidney disease. And we have seen in this, as we can see in this slide, the patients of diabetic kidney disease without dialysis, when keto acid supplementation was done, there's a delay in reduction of GFR in these patients, as we can see in this slide. And then there was a decrease in protein excretion when keto acid supplementation was done in these patients. Then, then they were also studied the level of serum albumin in patients who were given keto acid analogs. And the serum albumin was maintained in patients where keto acid analogs was given, and there was reduction in serum albumin also, in the urine albumin also, and the body weight remained stable in patients who were given keto acid analogs. So this study also suggested that uh, supplementation of keto acid analogs in very low protein diet patients with CKD was very helpful, and primary composite endpoint was set as need for renal replacement therapy initiation, and there was 0.5% reduction in the initial EGFR at any time during the assessment phase. And the study showed that significantly lower percentage of patients in KD group reached primary endpoint. 13% versus 42% in low protein diet group with keto acid analogs was shown. And that increases our confidence in keto acid analogs supplementation. Then there was another study where effects of restricted protein diet supplementation with keto acid analogs was done to see its effects on renal functions, blood pressure, nutrition status, and CKD disease, mineral and bone disorders in chronic kidney patients. And the systemic reviews suggested that these patients who were given supplementation of keto acid analogs for more than 6 months of follow-up reported with significant increase in EGFR in these patients. And restricted protein diet supplement with keto acid analogs effectively improved kidney functions in these patients, preserving the EGFR, diminishing the proteinuria and blood pressure levels, and bone density was maintained. And VLPD with keto acid analogs appears to be providing more effective measures in slowing the decline of GFR, lowering the blood pressure, and reducing the serum PTH levels, and increasing the serum calcium levels. So the meta-analysis uh, with keto acid analogs have shown that it slows down the progression of CKD. Now, 10 randomized controlled trials and 2 non-RCT trials comprising of 900 patients were pooled and analyzed, and they came to the conclusion that renal function indices were compared between very low protein diet with keto acid supplementation and control group. Then we've seen the effects of keto acid analogs was in delaying the GFR deterioration, this, maintaining the serum creatinine levels and urea levels or slightly reducing them in long term, and protein energy wasting was avoided in these patients, and the effects on serum albumin, cholesterol, calcium, and phosphorus and PTH levels were favorable. A restricted protein diet supplementation with keto acid analogs was found to significantly delay the progression of CKD. P-value was 0.008, particularly in patients with an eGFR more than 18 ml per minute per 1.73 meter square, and the p-value was highly significant, 0.0001. So no significant change in eGFR was found when compared to very low protein diet and low protein diet. In addition, compared with placebo, the keto acid analog did not cause malnutrition. They decreased the phosphorate levels and did not lead to further changes in disturbance in calcium levels, and they slowed down the progression of CKD to ESRD, and they delayed the uh, decline of GFR in these patients. Now, this slide also shows that when uh, keto acid analogs were given, there was favorable response in patients in delaying the decrease of GFR, as shown in this slide. So now we can we have the evidence to say that keto acid analogs are effective and safe in patients with diabetes or no diabetes, uh, and with dialysis or no dialysis, uh, the keto acid analogs have beneficial effects. The studies by Barsotti et al. Were the only ones that examined insulin requirements and found that there was significant decrease in insulin needs in patients of diabetes with CKD. Fasting glucose levels significantly reduced during keto acid supplementation with unstandardized mean difference of 0.27 milligram per deciliter. And in RCT by Zhu et al. And Michele found a significant decrease in glycated hemoglobin levels in diabetic CKD patients who received keto acid analogs. Hemoglobin levels were also studied in 4 studies and showed a non-significant change in patients with keto acid analogs. No effects on calcium, reduction in phosphate levels, and slight non-significant reduction in potassium levels were seen when keto acid supplementation was done. When safety of keto acid analogs was studied in the patients with non-dialysis diabetic kidney disease, it was seen that there was decrease in protein excretion in kidney by the kidneys and reduced GFR delay, as we have seen in other studies also previously. So to conclude, the summary of evidence provides the systemic review evaluating a protein restriction diet in combination with supplementation of keto acid analogs in patients with non-dialysis diabetic kidney suggests favorable effects on uremic burden, glucose metabolism, and progress of renal damage. The diets supplemented by keto acid analogs are safe, well tolerated over periods ranging from 12 weeks to 9 years, and with no evidence of adverse effects on nutritional status. So, take home message today will be that low protein diet and very low protein diets should be supplemented by keto acid analogs, and these should be considered effective and safe for patients with CKD, with diabetes or without diabetes, and ESRD patients. The meta-analysis have shown that decline in GFR may be attenuated in patients who receive keto acid supplementation, protein restricted diet. So, the message would be low protein diet with keto acid supplementation and other nutritional supplementations would be the measures effective in reducing uh, or prolonging the delay of ESRD. Thank you.
Great, sir. So it was quite an insightful session in terms of the condition that we were talking about, and also sufficient quantity of data. I think that is what we discussed in the later stages. And sir, if I can come to the questions that we have received from the audiences, sir, the first question I think it is already, I mean, discussed. Though I'll just even ask once that
Excuse
Ankur
me,
sir,
the
your
voice
voice
is
is
not
not coming
clear.
properly.
okay, am I audible now? Is it
नहीं सर,
Voice
आपकी
is
वॉइस
not
इको हो रही है सर.
proper.
नॉट प्रॉपर सर.
Yeah.
just is it any better now?
Still
नो
not.
सर, अंकुर सर आपने कोई और डिवाइस से आपने वेबिनार वगैरह तो नहीं ओपन किया हुआ है?
No,
नहीं,
no,
मैंने
it's
तो
not that.
नहीं
नहीं
वेबिनार
नहीं
मेरा
सर,
नहीं
मैं
है.
अंकुर सर को पूछ रहा हूँ मैं सर.
हाँ,
No,
अंकुर
no,
सर की
no.
पहले तो आवाज अच्छी आ रही थी, अभी ठीक नहीं आ रही है।
सर एक बार लीव करके दोबारा ज्वाइन कीजिए अंकुर सर, आपका ना इको आ रहा है. आपने कुछ हेडफोन वगैरह तो नहीं लगाया ना?
None. अभी भी echo आ रहा
नहीं
है.
नहीं आ रही है, इको
Just
हो रही है बहुत
I'll
ज्यादा.
rejoin.
ठीक हो तो
सर आपका परफेक्ट है, सर आपका परफेक्ट है.
अभी आपकी आवाज तो ठीक आ रही है।
सर मेरा भी परफेक्ट है, आपका भी परफेक्ट है, सिर्फ और सिर्फ अंकुर सर की तरफ से कुछ प्रॉब्लम.
हम्म।
यस अंकुर सर. अंकुर सर से समथिंग. अंकुर सर आपकी वॉइस नहीं आ रही.
Hello, am I audible?
Yeah, yeah,
Is
this
it
is now it's okay.
okay? Got it. There might be some technical issues that I was facing, maybe. So, sir, I was also sharing that yes, it was quite an insightful discussion. Towards the end, also we had shared couple of data points when it comes to the keto analogs, as you were also discussing. So, the first question that I have, our audience is actually asking that. Is there any evidence of keto analog that can modify the pathology in CKD, or is it only a supplementation?
And the recent evidence what I have shown in RCT trials,
Correct.
they have suggested that there is reduction in progression of CKD in these patients. There has been delay in dialysis in these patients.
Correct.
Whether they are having diabetes or they are not having diabetes, CKD itself gets a better response with addition of keto acid analogs.
Got it. Sir, then what about the use of keto analogs on patients if they are on dialysis already?
No, in CKD patient, whether they are diabetes or they are not having diabetes, All CKD patients get benefit out of it.
And sir, what about dialysis patients who are already on dialysis?
That's shown in these slides today
Hmm.
that dialysis was delayed in these patients, and the patients who were on dialysis, the nutritional supplementation with keto acid analogs had favorable effects.
Okay. Sir, can you kindly tell what diet should you prescribe or recommend to the patient in patients who have a GFR less than 60 in terms of protein intake?
Now, the guideline is very clear. If the GFR is less than 60 and patient is not having diabetes, then 0.6 to 0.8 grams per kg body weight can be given.
Okay.
And as GFR declines, we initiate low protein, very low protein diet. That
Hmm.
comes to 0.28 to 0.43 grams per kg body weight
Hmm.
as per guidelines. And then when very low protein diet is initiated in stages C, CKD stage 3 to 5 or ESRD, then the role of keto acid analogs becomes more important to prevent protein energy wasting and to modify the course of decline of GFR.
Sir, then there's another question that is saying so that finerenone has a class effect. So can we use cheaper non-steroidal MRA like eplerenone?
Yeah, now the role of MRAs have come in last few years,
Hmm.
and the Fineron is recently available in our country also. And Fineron results are very promising as the data suggests in reducing CKD, in reducing complication of diabetic kidney disease, in heart failure, severe LV systolic dysfunction. So the drug has promising role. But then when epinephrine was not available, we used to prescribe steroidal MRAs like spironolactone, and we also prescribed epinephrine. Both are useful, but when it comes to be categorize the them, then if a patient can afford, then best would be Fineron. If we cannot afford, then we can start with MRAs other like spironolactone or epinephrine.
Okay, got it, sir. Thank you. And sir, we'll take a last question, which is from the audience, which is saying that which is the easy and practical way of calculating patient's protein intake?
That is done by by the body weight of the patient only.
Okay, so as per body weight.
As per body weight, yeah. The
Okay.
guidelines are now very clear. Normal person 1 to 1.2 gram per kg body weight. Patient with CKD, GFR less than 60, but more than 25, then zero point 0.6 grams per kg body weight. Then stage 3 to stage 5 CKD patients, then we reduce the protein intake further to 0.228 to 0.4 grams per kg body weight. And but in patients who are on dialysis, then protein intake has to be given normal from 1 to 1.2 gram per kg body weight, because then there is protein loss in dialysis also.
Okay. Great, so great. Thank you so much. So that was the last question that we took from the audience, and I am really thankful to you for joining us and sharing the data informations on this pressing condition called chronic kidney disease, and which is ever increasing for that matter. And I hope that the audience has been benefiting from the discussion that we did. Thank you, Dr. Mahendra Suri. Again, thank you so much. Have a very good evening. Thank you.
Thank you. Good night.
Good. Okay, Rahulji, I think we can end.